This talk is on indications for shockwave in teenage athletes and adolescent athletes. I'm a board member of the American Society for Medical Shockwave Treatment. We're a new society. There's an international society for medical shockwave treatment. And we're newly formed, and we're having our next meeting in Boston in March. So I encourage you, if you're interested in shockwave therapy, show of hands, anyone do shockwave therapy here? Okay, great. Anyone treat teenage athletes? Okay, excellent. All right. I'm going to start. No conflicts. All right, course objectives. When to distinguish between radial and focused shockwave therapy in teenage athletes. Which injuries can you utilize shockwave therapy? And how often can you perform shockwave therapy? So basically, there are two major types, radial and focused. Therapeutic effects of each of them. They create microtrauma and an inflammatory response. They stimulate angiogenic growth factors and stimulate ingrowth of neovascularization. They increase blood supply and they promote tissue repair. So when we think about shockwave causing microtrauma, basically the oxygen in the blood is what gets everything to heal, as we know. And if we want things to heal quicker, we bring more blood to the area. Now, there are lots of different ways to do this. You can do this through acupuncture. There are various ways of physical therapy and other modalities to do so. But the really neat thing about shockwave is that approximately 6 to 9 weeks after you initiate treatment, you're going to have new capillaries, new blood vessels will form in an area, say around a tendon, that were never there before. So this is a pretty powerful, not only short-term, but long-term tool. When we say that shockwave increases blood supply, we're not saying that there's going to be swelling to an area, but it just drives through certain growth factors, blood to go to an area that normally doesn't have a good blood supply. As we know, tendons and ligaments suffer from lack of blood supply. You look at the Achilles tendon, strongest tendon in the body, really poor blood supply. So if we could bring blood to the area, we're doing great. What are the benefits? In most, there are no absolutes, right? As we all know in medicine. But in most cases, nerve blocks are not required. Treatments usually take 5 to 7 minutes, but some of my colleagues put it on low settings of shockwave where it'll take 10 to 12 minutes. There's usually no downtime for athletes. The exceptions are fractures. So I tell my athletes, let's say they're suffering from an Achilles tendonitis or medial tibial stress syndrome. If they could still run, then they can run through it. If it hurts to run, then they shouldn't. But as long as they could run, it's okay during shockwave therapy, during the course of treatment, that they can still keep going. Because you try to tell an athlete to stop. I myself am a 37-time marathoner. I'm not going to stop. I'm not going to stop unless I'm broken, right? So fractures are what keeps you down, all right, when you're having shockwave therapy. The average efficacy is upwards of 75%. And studies are being done now that show that if you do both focused and radial shockwave therapy together, those numbers can increase. This is basically a chart that shows that growth factors basically can stimulate cellular growth, proliferation, cell differentiation. As we can see in the chart, this leads to tissue regeneration, which leads to tendon muscle repair and bone repair. So the initial use of the shockwave came from urology world in the form of lithotripsy, right? That was in the early 80s. Extracorporeal shockwave therapy, ESWT, I'll just shorten it by saying shockwave therapy today, was then expanded for musculoskeletal uses. Different forms of energy can have effects on the musculoskeletal system, resulting in pain reduction and tissue healing. Forms of shockwave. The two basic forms are focused, which is a wide field of pressure waves that become focused and then converge at a particular depth within the body. The three main forms of focused shockwave are piezoelectric, electromagnetic, and electrohydraulic. Thus, muscle, tendon, bone, and I'd even say ligaments are fair game, right? That's in our wheelhouse. Radial shockwave, otherwise known as radial pressure waves, it's not a true shock. They generate pressure waves at lower speeds and lower peak pressures, thus can be considered more superficial than a focused device. Applications over bone is not recommended, as it can be too painful for the patient, but there are exceptions. If you look at sesamoiditis in the foot, underneath the first metatarsophalangeal joint, if somebody has a nice thick fat pad, you could use focus for that problem. And it's basically what patients can tolerate. So if you could use a radial device on a bone patient can tolerate it, then go for it. My patients, they're not too happy about that. That's when I'll switch to a focused device. So if we limit radial pressure waves to soft tissue, muscles, tendons, ligaments, heavily padded bones, I would call that the safe zone. Now, I always tell my patients what's the difference between focused and radial shockwave. My best analogy is think of an ice cream cone. So the top of the waves, top of the ice cream cone, the waves go out like this. That's a radial device. The very bottom tip of an ice cream cone, that's your focus. So it's a good way to think of it. Indications for radial shockwave in the lower extremity, again, known as radial pressure waves, according to the ISMST, plantar fasciitis, Achilles, MTSS, IT band, peroneal tendonitis, posterior tib, and sesamoiditis. So let's look at these. In your teenage athletes, and by the way, in this, we're in 2025, at least where I live, I'm in the Atlanta area. Teenage sports are ultra specialized these days. And, you know, side note, I'm of the opinion that teenagers should be playing multiple sports. I think they get less injured doing it that way, but right now I have 13-year-olds whose parents think that they're going to the Olympics in soccer. We see that all the time. And sometimes we're treating the parents, not the patient, although, you know, patient always comes first, but it's the parents that we have to talk to more. So plantar fasciitis happens. I see that in soccer players, runners, basketball players. It's mostly mid-arch as opposed to adults who get mostly plantar medial calcaneal area plantar fasciitis. So we see it mid-arch. Achilles tendonitis. Right now I'm treating a 13-year-old runner who's a pretty exceptional runner, who's getting Achilles tendonitis. He's got very good running form, which I always take my runners out and check their running form to make sure that we don't have to correct that issue. But sometimes in a young developing body, when they run really fast, they could develop Achilles tendonitis. I haven't seen ruptures in the younger teens, but you can see ruptures in the older ones. But I think we see that more in the 20s, once they get out of their teens. Medial tibial stress syndrome, extremely common in my world. I treat at least 2-3 teenage athletes a day who are suffering from medial tibial stress syndrome. Again, side note, you have to look at a lot of times overpronation or overstriding can cause this. So, you know, we don't want to always just be mechanics and fix the problem. We want to do prevention too. So wherever we could do that with strength training, etc., we want to try to do that. IT band syndrome, I do see that in mostly distance runners who are in their teens, as well as some soccer players. I don't see it in the young tennis players. It doesn't happen that often. Peroneal tendonitis, posterior tibial tendonitis. Very often I see, if we're looking at like foot types as a generalization, the people who are the supinators typically will get more peroneal tendonitis, and the overpronators are more prone to getting posterior tib. Again, not always a rule. Last week I treated 2 ballet dancers, both 16 years old, on point, and one suffered from peroneal tendonitis, the other one from posterior tib. And both of those injuries were so bad that they couldn't get up on their toes. So this was definitely fair game for shockwave therapy. Sesamoiditis, I'll see this in athletes. Very oftentimes I'll see it following turf toe injuries. So they'll get turf toe and they'll also strain the sesamoids at the same time. So, you know, when somebody comes in with turf toe, I'll always check them out for sesamoiditis. All right, it's a good rule of thumb. All right, indications for focus shockwave. Fractures. Fractures, stress fractures. You see a lot of calcaneal apophysitis, too much of it. Some Osgood-Schlutters. Acute stress reactions. I'm treating more acute stress reactions these days than fractures. Bone stress injuries. So bone stress injuries, really just the last 2 years I've kind of discovered through one of our colleagues, Adam 1040, who's at Harvard, is doing a lot of research on bone stress injuries and using focus shockwave to treat it. Insertional Achilles, insertional every tendon, posterior tib, insertional peroneal tendons, sesamoiditis, non-unions work really, really well. It could take way more treatments. It's usually a once a weeker. So for non-unions, it could take 8 to 12 treatments once a week. And I filled in gaps as big as a centimeter, which is hard to believe, but it is true. Plantar fasciitis, ankle ligament strains, turf toe, and MTSS. So with fractures, you're going to treat them once a week. Quite remarkable that we're able to take a fracture, a stress fracture that normally takes 6 to 8 weeks to heal. I can tell you in practice, I'm healing at least 80% of them in 3 weeks. All right, and that's full healing on X-ray that you would normally see 6 to 8 weeks. Now we're seeing it in 3 weeks. So for an athlete, mid-season, right? They're soccer players. We get a lot of club soccer players, right? Not necessarily playing for their school, but for these clubs, and they have to get back as quickly as possible. So if we're minimizing boot time to 3 weeks, maybe 4, instead of 6 to 8 weeks, that's a game changer for athletes. Calcaneal apophysitis, we're able to treat that as well. Again, just driving blood to the area. It's safe. Osgood-Schleier's as well. And we're not arresting growth plates by doing shockwave therapy. So you could feel safe in terms of utilizing it. That was a fear. There was a study done on animals which showed that it arrested growth plates, but on people it doesn't. So thank goodness. Contraindications, and I have to say, thank goodness, in my practice, I've never come across any of these in teenagers. But if they're on blood thinners, pregnant, active cancer, and osteomyelitis, you want to avoid doing shockwave. And this goes for adults as well. Okay, some studies. Use of shockwave therapy for Osgood-Schleier's. Results were 75% of the patients were improved. Out of the boys, the median age was 14, girls aged 12. They were followed up on average 5.6 years later, and no side effects or long-term complications reported. 2023, Shopshack et al. Looked at focused shockwave for youth sports-related calcaneal apophyseal injuries. Results: full recovery in 1 to 3 sessions. For me, it usually takes 3, but let's look at the research. Average return to play was 2 weeks. I found more like 3. No recurrence up to 3 months post-treatment. And without shockwave, the usual treatment is rest away from training and competing for 2 to 3 months. So just look at these numbers. I mean, the parents want them back. The kids, sometimes they do want, the younger kids, like the 12 and 13-year-olds, they're like, yeah, whatever, I'll get back in the game. It's really funny when they get into high school, how that changes. They want to get better. They are pushing to get better. The younger kids, the parents are looking for them to get better. We as physicians, we want to get our patients better no matter what. All right, again, pediatric overuse injuries in sports. I touched on this before with specialization. This study by Hong, overuse injuries are chronic injuries seen when repetitive stress is placed on bone or soft tissue without enough healing time or recovery. According to the previously mentioned Shapshak study, this sets up nicely to use shockwave therapy to enhance pain relief and long-term analgesia. Proposed mechanisms on what shockwave actually does to bone and tissue: modulation of P substance release, reduction in pain mediators such as calcitonin and G-related peptides, hyperstimulation analgesia, which alleviates pain due to high sensory input that is applied to the site of greatest discomfort. So let's talk about that a little bit. Focused shockwave. So the way focused shockwave, the very interesting thing about it is on normal bone or tissue, these are sound waves. Sound waves go through the tissue and patients don't feel anything. You then put the shockwave on an area of inflammation, fracture. The sound waves basically bounce back and then the patient gets a pain response. And I could get to within the millimeter or 2 of precisely where the problem is by the patient's response. You don't need to use an ultrasound machine to get there. follow what the patient feels, and it's usually pretty spot on. So if you know where your fracture is, and you put the probe, let's say the probe, the front of the probe is about this big, maybe a little bigger, put the probe right on that area of bone where you see it on the x-ray, they should be lighting right up. And the response is, ow, that hurts, okay? And then what you do, you have the controls in your hand or dial, that you're able to dial it down to where they could withstand the treatment for however long. You know, my machine is typically about 5 minutes. So I try to titrate them. I always try to increase, we try to get to higher energy levels, because the working theory is the higher the energy level, the quicker the response. My machine that I use goes up to 0.35 millijoules per mm squared. Sometimes the patient will start off at 0.03. And sometimes they stay at 0.03 or 0.05, but they still get better. So it's an interesting thing. You know, we're always thinking that we have to go higher, and patients usually do go higher as the treatment goes on, but sometimes even at a low level, you'll still get a good response. And the only reason why you're at a low level is because it hurts the patient too much, all right? But you always want to put it at a level that they can tolerate, because if you put it up too high, they're not going to come back again. All right, that's one thing. All right, mechanotransduction, the mechanism by which shockwave triggers angiogenic and tissue regeneration and bone remodeling at cellular and molecular levels. Shockwaves work by emitting acoustic waves that carry energy and propagate through tissues. ESWT generate interstitial and extracellular responses, which can lead to pain relief, vascularization, protein biosynthesis, and cell proliferation. Combination of these effects leads to tissue regeneration, reduction in pain, and improving functional outcome in injured tissue. Protocols, again, I mentioned before, with plantar fasciitis, teens experience more mid-arch than insertion of plantar fasciitis. If the pain scale is below 7, and I encourage you to do some sort of, like I do VAS scores, visual analog scale scores on patients every visit. So I get a baseline at the first visit, and let's say they come in and they're 6.8. And each subsequent visit, I do VAS scores again. And it's really funny with athletes, they're very competitive. They're even competitive with what levels they're at, that are putting them on, what settings. They're competitive about, well, I was 6.8 first time, now I'm 4.2. You know, they love that. Everything's a competition, especially with teenage athletes. So I will do radial shockwave treatments if the pain is under 7, 4 to 6 treatments spaced every 3 to 7 days apart. Now, the original ISMST recommendations were once a week. I found it because a patient came in and they said, in 2 weeks I have such and such competition or such and such race, and I have to be better by that. So, I said, well, it's normally a once a week thing, but let me try 3 days, 5 days. Tried it, guess what, it worked. I got the same outcomes as waiting, 4 to 6 weeks. My typical thing, so today's Monday, I'll give you a for instance. Let's say somebody's coming in for a soft tissue problem, plantar fasciitis, Achilles, MTSS, and today's Monday. We could do treatment today, treatment Friday, next week Wednesday, and then the following Monday. So that's 4 treatments in 2 weeks. And most patients are, they tip over pain-wise, where the pain diminishes, usually after the third or fourth treatment. So this is a cumulative thing. Don't set up expectations that you're going to be better after the first treatment. Doesn't happen. We're playing more of a long game, but when I say a long game, it's really just a couple of weeks, usually 2 to 3 weeks, and get our patients better with soft tissue injuries. If their pain scale is 7 to 10, we're going to do combination therapy, and we're going to do focused first. You do the focused treatment first, followed by the radial in the same session, again, 3 to 7 days apart. For plantar fasciitis, one of the big pearls for both kids and adults, when the morning pain goes away, the issue is usually resolving. All right, this is radial shockwave on the plantar fascia. We're seeing Achilles tendonitis, non-insertional. So we're going to do radial, again, the same 3 to 7 days apart, 4 to 6 treatments. So if your patient comes in at treatment 4 and they say, you know what, I have no pain anymore, they're done. You don't have to do any further treatment. If they say, well, I'm 80% better, I want a little more, you do a 5th treatment. You don't have like a cookie cutter way of doing this. You go by the way the patients feel and how they're doing. Occasionally with teenage athletes, that number drops down to 3. So we can sometimes get them better after 3 treatments. But I always give them a disclaimer: if you're not better, if you see that the pain comes back in the next week or 2, get back in for another treatment. The good pearl for Achilles tendonitis is when they walk downstairs in the morning, they'll no longer have pain. So the question you should always be asking your patients when they have Achilles tendonitis, do you have pain when you walk downstairs? And very often they're going to tell you, I have to go like a child, go 1 step at a time because it hurts too much when they're dorsiflexing the foot to clear the step. Medial tibial stress syndrome. We do radial treatments, again, 4 to 6 treatments every 3 to 7 days. When these patients come in, shin splints, you want to put an X-ray marker on the bone. If they're having bone pain, you want to put an X-ray marker there so that you can see it better on the X-ray and rule out a stress fracture. Okay, we want to make sure that we're not in that zone. If the issue is simply soft tissue, if it's just simply medial tibia, I use radial shockwave. We're also seeing patients who have soleus pain. I call it lateral tibial stress syndrome. I don't think it's a real term, but I roll with it, okay? Again, it's the same protocol. Perineal and posterior tib, radial, 4 to 6 treatments, 3 to 7 days apart. On the image on the left, we're seeing the perineal tendon, and on the right, we're seeing posterior tib. But we don't want to do insertional with the radial device, right? It'll just hurt them too much. Stress fracture, stress reactions, non-displaced fractures, calcaneal apophysitis. We use focused shockwave once a week, typically for 3 to 4 weeks. And as I said, usually 80+% of the time it's 3 weeks. I always take follow-up x-rays at 3 weeks to see our progress, see how we're doing, see if there's any improvement. Usually there is, but if there isn't, then we have to go a little further. Jones fractures take a little longer. They're usually 4 to 5 weeks, 4 to 5 treatments. X-rays taken after 4 weeks to assess. Now I know the pictures really don't do it a lot of justice, but when I saw it on my X-ray monitor, I was able to see it better. This is just kind of like screenshots, but on the left, this is a boy came in. You could see the gap on the left, and on the right, it filled in quite a bit. All right, that's just after 3 weeks, totally pain-free. I had him in a boot for 3 weeks because he couldn't walk coming in. Had him out of the boot, did a hop test on him, and he was able to return to sport right away. He came in for another issue, and that was like 6 months later, and never had an issue with this again, which is great. Shockwave settings. I'm trying to give you a playbook here. So I have a Zimmer radial device and a Storz focus device. On the Zimmer, there was a study, I'm sorry I don't have it handy, but a study was done in Germany that basically showed the higher the energy level, like the millijoules, the higher the energy level, the better the efficacy. It was a pretty large study. So I try to go as high as I can. So on my Zimmer radial device, I try to go to 16 hertz, and I do 3,400 shocks. And on the Storz focus device, the range is from 0.01 to 0.35 millijoules per mm squared at 8 hertz. All right, if you go at 4 hertz, which was the original recommendation, typically it takes about 10 to 12 minutes, but it's a lot more suffering for the patient. So I have a German colleague who said, well, I have patients paying cash for this. And basically the perception in his community is if they're paying money for 5 minutes versus 12 minutes, they want the 12 minutes. And I'm saying that my patients are in pain when they get shockwave, but they'd rather 5 minutes to get better quicker than go 10, 12 minutes to do it slower. I don't know, to each their own. All right, but you get to the finish line sort of the same way, but yeah, I think you'll get a higher efficacy if you go with the highest energy, whatever machine you have, go with that. I just found out that Zimmer has been working on a focus device. It's a piezoelectric device. They've been working on it for a long time, and it's just about to come out, at least in the United States. They're just waiting on final FDA approval, which is, it's always nice to have other machines that you can use. At the moment, the only thing that I know of in the US is the Storz device. When we're doing shockwave, as I said, you want to put the probe where it hurts the most. And I refer to that, I tell my patients, we're looking for the pain sweet spot. Where it hurts the most is most likely going to give you the most benefit. And when you're doing your treatment, we're not robots, right? We can move slightly, the patient can move slightly. So you always want to be in constant communication with the patient as to whether or not they're still feeling that pain sweet spot. Because if they don't, you need to redirect, right? You need to put that probe where they're feeling it. What are the treatment goals? So in the first treatment, we want to start low, and then we'll work our way up, right? We titrate up or titrate down. With the focus device, what I find is that you can start off at a certain level, and then you get this wave. Patients feel a wave. And sometimes that wave can go really, really high, and they're like, whoa, they're really painful. Another thing that I caution you is, I always ask my patients, especially the first time they come in, when you get a blood test done, are you passing out? Okay, these are the same patients who get a vasovagal reaction when they experience some pain. So if that happens, you want to lean them back, right? Put the table back flat, or put it down. Don't have them sitting upright. All right, lean them back, because if they're going to pass out from pain, it doesn't happen a lot, but every now and then it can happen. It's usually the the big football players, the teenage high school football players, those are the ones that pass out the most. On the second treatment, and always record what their levels are each visit. So let's say they start off at 0.10 millijoules per mm squared. At the second treatment, that's going to be my baseline. I'm going to start them there and see if we can go higher. In most cases, we could usually go a little higher. Some cases we could go double. And the patients are blown away. And I put it back to that 0.10 and they're like, wow, I hardly feel it today. And I felt it so much 4 days ago. So, you know, it's sort of like a palpable thing that the patients, you get that good response from them. Third treatment, again, start at where you were the second treatment, try to go higher. As the problem improves, this is the cool thing about shockwave, whether it's rated or focused. As the problem improves, you can usually go to higher energy levels and they don't feel it as much. Okay, so on a first treatment fracture, it might be at 0.07. And by the time we get to the third treatment, they could be at 0.35. It's really neat. And then you see their VAS scores go down, right? So the patients realizing, you know, if you get a fracture, patients are very insecure. They're very, very insecure about, you know, can I walk? Can I run after? So you have to guide them, but you have to give them the confidence. Once you see that the fracture's healed, from your perspective, from a clinical perspective, then you have to guide them how to get back into their sport. And once they start running on it pain-free, they usually go with it. Yeah, that's the other thing down here. Get goals. So I always tell the patient at the first visit, I want to get you under 2 as close to 0 as possible, right? So patient comes in for that, whatever that last treatment is, whether it's treatment 3 for fractures or treatment 4 for soft tissue. They come in and their pain is a 1.1 and they start off at like 5.8. You know you're pretty much there. And you tell the patients, you're probably better now, with the disclaimer, if you're not, get back to me, because, you know, they're not machines. Post-treatment guidelines. We tell the patients avoid ice, avoid NSAIDs, but they can take acetaminophen. It is normal to have increased pain for 1 to 3 days following treatment. So I give my patients a handout saying all these 3 things, plus I give them my cell phone. Gives them the confidence that they can reach out, they can text me if they're having an issue, but you always want to let them know that they could have increased pain or soreness. Otherwise, if you don't tell them that at the front end, you're going to be getting calls quite a bit. So I learned by experience, and now I have this handout. I'll typically use combination therapy of both radio and focused shockwave when vascular pain is above 7. I use focus first, followed by radial. The radial usually doesn't hurt so much. They may get some little bit of discomfort for the first minute, then that usually goes away. If you think the fracture is healed, have them perform a functional hop test. Does everyone know what that is? But basically you hop on the affected foot 25 or 30 times. And if they don't have any pain, then they're usually ready to return to play. When using the focused, let your patients know that it should feel uncomfortable, but not too painful. So again, dial it down, make it so that they can get through that session. That's all I have. This is my contact information.